Hi, this is Brandy from Mana Health Partners, and I want to thank you for taking your time out of the day to watch this video. So I know we have a lot of education and things are constantly changing in nursing, in the medical field, as nurse practitioners and physician's assistants. So to be able to do an updated video and get the latest information is really important. So today we're going to talk about evidence-based practice at the point of care, how to safely prescribe for nurse practitioners, specifically in the state of in Texas. So a lot of nurse practitioners are either new to the field or haven't had much experience, specifically in skilled nursing facilities. Others have been practicing for a while, but may not have worked in this particular setting before. This presentation is for all of you because prescribing safely in skilled nursing requires a clear understanding of both clinical best practices and Texas-specific regulatory requirements. In Texas, that means understanding how the prescriptive authority agreement defines your scope of practice, which can be delegated, and how to stay compliant while delivering safe, evidence-based care. We'll build on that foundation together as we move forward through today's training. Before we get started, let's take a quick look at what we'll be covering in this training. We'll begin by reviewing the scope of practice and the role of the nurse practitioner in skilled nursing and long-term care. Because this training is specifically focused for Texas, we'll focus on that scope, which is defined through the prescriptive authority agreement, which outlines the collaborative relationship between the nurse practitioner and the delegating physician. We'll also discuss what can and cannot be prescribed in Texas, including the delegation of dangerous drugs and controlled substances, Scheduled 3 through 5, and highlight the legal and regulatory guardrails that guide safe prescribing in this setting. From there, we'll explore how to integrate evidence-based clinical tools and apps into everyday decision-making. Because safe prescribing isn't about guessing, it's about reliable, accessible resources at the point of care. We'll cover lab ordering and medication monitoring protocols, when to order, how often, and why it matters for patient safety and regulatory compliance. Then we'll bring it all together by discussing antibiotic stewardship and how to use McGreer's criteria in combination with Interact Care Pathways to discuss appropriate evidence-based treatment decisions. We'll walk through the before you prescribe algorithm to build a consistent clinical thought process and highlight some of the most common prescribing pitfalls in this environment. Finally, we'll wrap up with documentation, regulatory considerations, and a few additional resources you can reference after this training. This training isn't just about sharing information. It's about building confidence and consistency in how we prescribe. If questions come up as you watch, you can always reach out by email, and I'll be happy to support you. When we talk about the role of the nurse practitioner in this setting, we're really talking about the heart of what we do every day. As nurse practitioners in skilled and long-term care, we're responsible for managing selected medical problems, those conditions that fall within our training and scope of practice as defined under Texas law and through the prescriptive authority agreement with our delegating physician. That means we can order diagnostic tests, initiate appropriate therapies, order physical and occupational therapy when clinically indicated to support patient recovery and function. We also have the authority as delegated to initiate, monitor, and adjust therapies for certain uncomplicated acute illnesses, things like mild infections, respiratory issues, or pain management when appropriate. A big part of our role is to monitor and manage patients with stable chronic conditions like hypertension, diabetes, COPD, and depression. as well as behavioral health conditions that have an established diagnosis and treatment plan. This scope allows us to intervene early, keep patients stable, and often prevent unnecessary hospitalizations. And it's all grounded in evidence-based practice and Texas regulations that guide nurse practitioner practice and prescriptive authority. This slide is a cornerstone of what we do as legal practitioners. It outlines the clinical and legal guardrails for prescribing across acute, chronic, and preventative care. Many of our screens will have boundaries, will have references at the end, will have the codes from Texas that you can look up and find those regulations that I reference in here. Everything that I use in this slideshow is referenced. Everything that I use is CMS required or the Texas Board of Nursing required. So I don't just input information from myself. This is actual evidence-based practice and actual legal law. In Texas, nurse practitioners provide care under the scope defined by their education and training and through a prescriptive authority agreement. From now on, we'll call it a PAA with a delegating physician. That means our ability to diagnose and manage medical problems must always stay within what's delegated to us and what's allowed under state law. Acute care. So when a patient presents with a new or worsening issue, we can prescribe short-term treatments like antibiotics, steroids, or other appropriate therapies, as long as we document clinical justification and stay within regulatory boundaries. Chronic care. For conditions like diabetes, hypertension, COPD, heart failure, thyroid disease, and depression, we have the authority under the PAA to initiate, titrate, and maintain ongoing medication regimens. This requires appropriate lab monitoring, using evidence-based practice guidelines, and complying with DEA requirements for controlled substances. Preventative care. We can order vaccines, vitamin supplements, and screening labs like lipid panels, A1C, and thyroid labs as part of maintaining or improving baseline health. The big reminder here, prescribing isn't just clinical, it's legal and it's regulatory, especially when controlled substances are involved. Your DEA registration, state law, and PAA documentation must align. That's why understanding your scope of practice and prescriptive authority in Texas is critical before you ever hit e-prescribe. When we talk about managing selected medical problems, we're really talking about what lies at the core of the nurse practitioner in, that should say, Texas. Under state law, nurse practitioners have the authority to diagnose, treat, and manage common acute and chronic medical conditions that fall within our training, scope, and certification. That includes being able to order diagnostic tests, initiate and adjust the treatments, and monitor a patient's response to therapy. We can initiate, monitor, and alter therapies for certain uncomplicated acute illnesses, things like mild infections, minor exacerbations, or chronic conditions, pain, or behavioral changes that can be addressed at the bedside. We're also responsible for monitoring and managing patients with stable chronic illnesses. That's a huge part of what keeps residents stable in long-term care and prevents unnecessary hospitalizations. The key idea here is knowing your scope, practicing within it, and using evidence-based practice tools to guide your clinical decisions. This is where being proactive makes a difference in both patient outcomes and regulatory compliance. When we talk about prescriptive authority in Texas, it's important to remember that all nurse practitioners prescribe under a PAA. There's no independent or autonomous prescribing here. The PAA outlines what can be delegated by the physician, and it must align with Texas law and the nurse practitioner's education and certification. And as you see in your collaborative agreements, it states such that under Texas law, nurse practitioners can prescribe both non-controlled and controlled substances as delegated in the PAA. Prescribing Schedule II controlled substances is only permitted in very limited circumstances, such as hospital-based or hospice settings, and must meet strict requirements. Every nurse practitioner must check Texas PMP aware prior to prescribing controlled substances. This is required by law and is an essential step for patient safety and regulatory compliance. The bottom line is prescribing isn't just about signing your name on an order. It's about making sure your prescribing is clinically appropriate, delegated correctly under your PAA, and fully compliant with state and federal regulations. This slide is important because it highlights exactly what we do as nurse practitioners in Texas, are legally authorized to do when it comes to medication, including how to prescribe, order, or administer medications, only as delegated under the PAA and within their scope of practice. In our SNF setting, we don't typically dispense or administer medications ourselves. Nursing and pharmacy handle that. But our name is on that prescription, which means we are legally responsible for ensuring it's clinically appropriate and compliant with state and federal laws. For controlled substances, you must have an active DEA registration, but that's not enough. You have to follow DEA regulations, Texas law, and your PAA delegation. And because we practice in a SNF and not a hospital base, we are not permitted to prescribe Schedule II controlled substances here. Schedule 3 through 5 are allowed under the PAA, and the PMP aware must be checked before prescribing any controlled medications. Remember, even if we're not handling the medications or handing those medications to the patients themselves, we are the initiating prescribers, and that carries clinical responsibility. I know this slide looks a little busy, but that's intentional. When it comes to pain management, especially involving controlled substances, the prescriber carries a significant amount of responsibility. If we make the decision to start a patient on medication for pain management, we have to be able to fully support that decision in the medical record. In Texas, this is especially important because controlled substance prescribing is tightly regulated and subject to review. There are 3 big things to keep in mind. Clear medical indication. The reason for the prescription must be explicitly documented, not just pain. Be specific about the diagnosis, the severity, and why pharmacologic management is appropriate. Judicious documentation. This includes the patient's history, your assessment, the rationale for initiating medication, and why this is the best next step in the plan of care. A monitoring plan. You need to show how you will assess, evaluate effectiveness, and monitor for signs of misuse, abuse, or adverse effects. Beyond the initial prescription, think ahead. What's the exit strategy? How often will pain be reassessed? Are there non-pharmacologic or lower risk alternatives to consider? In our SNF setting, Schedule II controlled substances cannot be prescribed by a nurse practitioner. So for pain management, our prescribing is generally limited to Schedule 3 through 5 narcotics and non-controlled options. PMP aware checks are required before prescribing controlled substances. When you log in and you see what the patient's overdose score is, there is a place where you can download that PDF. Download that PDF to your desktop and upload it into the patient's medical record under miscellaneous. It's proof that not only did you check the PMP aware, but that the results are under the miscellaneous tab. Pain management is necessary for many of our patients, but it must be done through thorough, intentional, and defensible cases. So a couple of things you want to make sure of on this slide, and it's on the right-hand side. We want to make sure of the location of the pain. We're not just going to write pain. How much is the frequency and the duration, the intensity and the severity, the quality and the character, the onset and the course, aggravating factors, relieving factors. Those relieving factors, how often are we doing them? Associated symptoms, impact of function, and interventions and response. That should be included in your HPI and is very important when you start a patient on pain medication and when you're evaluating a patient for pain management effectiveness. When it comes to controlled substances and pain management, the best thing we can do for both patient safety and provider protection is to make sure there's one consistent provider managing the plan of care. Pain management should be the one following the patient, meaning the designated pain management provider is responsible for evaluation, dose adjustments, and refills. As nurse practitioners in skilled nursing and long-term care, our role is to support the plan, not to create multiple layers of prescribing. That means no refills unless absolutely necessary. No dose adjustments unless you are the designated pain prescriber and it is clearly indicated. Avoid multiple providers prescribing for the same patient. That's where too many things go wrong. Having too many hands in the pot doesn't just create confusion, it increases the risk for medication errors, diversions, and regulatory red flags. Keeping pain management with one provider keeps the plan consistent, traceable, and safe. So if you initiate pain management, call the pain management team and let them know that you've initiated a scheduled narcotic and ask them to follow the patient. So you'll still have to do the initial plan, the initial assessment, and even PRN monitoring. But as far as updating the plan, after you've put it into place, once you turn it over to pain management, they will manage it from here on out. This is a really important slide because it gets to the heart of how we make our medical decisions. How do we know which medication is the right one for a patient? It's not what we used to do 5 or 10 years ago. Medication is constantly evolving, and so should our practice. We don't rely on what worked best for the last patient. We rely on evidence-based practice, what's most appropriate right now, backed by the most current research and clinical guidelines. That's where these clinical tools and apps come in. If you're not using at least a few of these resources, you're making prescribing harder than it needs to be. These tools simplify your workflow, help you make more accurate, and more importantly, they help you prescribe safely. They can give you dosing recommendations, interactions, contraindications, renal and hepatic adjustments, and guideline-based treatment plans at your fingertips. This is how we stay current and protect our licenses while giving patients the best care possible. 2 examples is ordering amoxicillin 500 milligrams twice a day for pneumonia, Any of these applications that you have, either on your phone or your desktop, will tell you that unless you have chronic kidney disease and a GFR of lower than 30, your dosing should be 500 milligrams 3 days. So even though you know amoxicillin is the best choice, pull up your application and verify your dose, your frequency, and your length of treatment. One other example is giving zithromycin 500 milligrams every day for 7 days. That's not how you order zithromycin. Unless you have infectious disease involved, zithromycin would be 500 milligrams for day 1 and 250 milligrams day 2 through 5. Those are just 2 examples of how if you went into UpToDate or EMRXR or Micromedex, you would be able to find what the protocols are. So MANA as a whole do not use protocols. We used evidence-based practice. You won't be able to get onto a MANA site and look for what evidence-based practice is, or if you have pneumonia, you're going to follow this protocol. What you're going to do is after you have your diagnosis, you're going to come in here and utilize evidence-based practice. It's critical that we use this. So when the physicians come in, they know we've done the right thing for the right patient, for the right diagnosis, for the right length of time. That's how we define ourselves as mid-level providers and utilize evidence-based practice. So here's an example of Lexicomp. It's the gold standard for real-time drug information. I don't use this information necessarily. This isn't one of my apps that I use, but it is the gold standard for real-time drug information for adults, for pediatrics, for renal and hepatic dosing, which is very important. It gives you drug-to-drug interactions. It has lab monitoring, adverse effects, and therapeutic ranges. It also gives off-label dosing with supported evidence levels. This is an amazing evidence-based practice app. This one is Micromedex. So it is comprehensive. It is per indication and route. It does have black box warnings. It does have evidence grading for off-level uses, and it's IV compatibility, pediatrics and geriatrics, and we just so happen to work with the geriatric population. So this is integrated into many hospital systems. We don't have it integrated with ours, but it's an app. You download it to your phone. You can look any medication up. Again, on all these slides, you've either got references or you've got URL numbers where you can utilize this information and find it. UpToDate, loved it when I was in school. I don't use it necessarily in my daily practice. It does have clinical decision supports with guideline integration. It's good for condition-specific treatment algorithms, which I find is a little bit over my head as far as the algorithms with recommended dosing. I already know that with the apps that I'm using. Evidence summaries and references related to literature. I don't have time to look at the literature behind every decision that I make, but it is evidence-based. A lot of nurse practitioners use this and they love utilizing UpToDate. So that's always a good option. My favorite, or at least one of my favorites, is Hippocrates. So rapid verification of drug dosing interactions, and then even pill identification. So if you're looking to find out what pill was dropped on the floor so you can let the nurse know they dropped it and you need another pill, good information there. Basic guideline summaries. It's useful for outpatient and telehealth encounters. It's easy to use at point of care. You can open it up on your phone in the patient's room, and then you can show them the evidence-based practice based on that. And they also have, it's free, so that's great, but then they have the premium versions as well, which I pay for, which gives you more information, not just on the medication, but on the diagnosis itself. This is by far my favorite app. So it's EMRA ABX. So it's an antibiotic app. And this is the picture right here of the app. So when you go to the App Store, you'll pull it up. When you open the EMRA, it will give you a list right here of systems, body systems. Then you click into the body systems, and when you get into the body systems, it will give you a list of diagnoses for that. So if you're looking at, let's say, GI, it will give you gastritis. It will give you gallbladder. So you click into that one section, and then it will list a whole bunch of antibiotics that you can use. This is an antibiotic app. So based on that, if you have 4 choices and the patient has 3 allergies, we already know what we can use. And on the bottom of that, it gives you, if you have kidney or liver issues, it gives you those as well. So it's absolutely my favorite tool for quick and easy decision making. It's designed for emergency medicine, ironically enough, which makes it fast, clear, and clinically practical. For nurse practitioners in long-term care or primary care, that's a huge plus because we're often making antibiotic decisions at point of care, not after hours of research. With EMRA, you can quickly find first-line and alternative antibiotics based on the suspected source of infection. You can check common pathways, pathogens, typical coverage, which is incredibly helpful in long-term care associated infections like UTIs, pneumonia, skin, or soft tissue infections. You can see standard dosing, including renal adjustments right there in the app. And it gives you a sense of what's evidence-based and guideline instead of relying on old habits just as give a Z-Pack. This app isn't meant to replace any clinical judgment. No app is, but it supports rapid, appropriate, defensible prescribing. And one of the tips that I use is I use this EMRA antibiotics with McGear's criteria and interact pathways before starting any antibiotics. That combination drastically reduces inappropriate prescribing. This slide is a great reminder of the procedural side of our role as nurse practitioners. Obviously, in skilled nursing, there are some procedures we won't be doing. For example, a pap smear isn't something you're going to perform in this environment. But many nurse practitioners are trained and fully within their scope to perform a variety of other procedures. This includes things like joint injections, PEG tube changes, suprapubic catheter replacements. If it's something you're trained to do, and it falls within your scope, you're absolutely able to perform it. That being said, scope isn't just what's legally allowed. It's about being competent. So if you've never done a joint injection before, it would be inappropriate to just pick up a needle and try that. In that case, it would be expected that you receive additional training, supervision, and guidance before independently performing the procedure. Me personally, I've never done a joint injection. I know there are landmarks that you need to do. I would want to, and I have watched the doctor and nurse practitioners give joint injections. I would want them to walk me through it before I went to the patient's room. I would want them to supervise me and give me feedback as I'm doing that. And I would want to do that multiple times for each specific joint before I felt comfortable. So if you've done that for shoulder joints and you feel comfortable, and that's the only thing you've done joint injections for, do shoulder joint injections. If you've never done a knee, don't try a knee. Make sure you get the experience. And a lot of physicians or nurse practitioners are willing to walk you through that and help you. The takeaway here is if it's within your scope of practice and you are trained, you can do it. If you are not trained, do not do it without proper guidance. This protects you, your license, and your patient. This slide is a simple but really important reminder. Sometimes in the hurry of rounding or doing an initial assessment, providers order labs without doing a thorough review of the patient's diagnosis, current medications, or past lab results. But here's the reality. In order to recognize a meaningful change in the patient's condition, you need a baseline to compare to. Baseline labs are not just a box to check. They're how we identify early shifts, catch complications sooner, and make safe prescribing decisions. If we start a patient on a medication that impacts the liver, the kidneys, or electrolytes, we need to know where we're starting from. If they have a chronic condition, baseline values help us determine whether what we're seeing is new or part of their chronic picture. This is particularly important in long-term care and primary care, where we often inherit these patients with fragmented medical records. Take the time to establish or review baseline labs up front, and it will save you time, protect the patient, and keep your documentation defensible. This slide is here to remind you that our decisions around lab monitoring aren't based on personal preference. They're grounded in national standards and regulatory expectations. So when a physician says they don't need that or I don't want to order that, the labs that we have in this slide are based on regulatory expectations, national standards, evidence-based practice. So multiple agencies and organizations outline when and why labs should be obtained, both at baseline and for follow-up. These include a CBC for infectious disease vaccination guidance, including lab-based protocols, the FDA for medication labeling and monitoring recommendations, the National Institute for Health for clinical practice guidelines and evidence-based treatment standard, CMS, which sets regulatory expectations for long-term care and skilled nursing, and the Joint Commission, IDSA, and other specialty organizations for disease-specific best practices. When your documentation shows that your decisions align with these standards, it does more than just justify your care. It protects you legally, it strengthens your clinical judgment, and it keeps the facility survey ready. So when you're ordering a lab, you're not just following personal practice, you're aligning the national evidence-based guidelines and regulatory expectations. The CBC and CMP are some of the most foundational labs that we use in clinical practice. This gives us a broad snapshot of a patient's overall health. The CBC for infection, anemia, or hematologic issues, and a CMP for liver, kidney, electrolyte, and protein status. For new admissions or medication starts, this is your baseline anchor. It allows us to detect changes early, adjust medications appropriately, and catch complications before they turn into crises. These are also some of the most defensible labs to order in long-term care and primary care because they're evidence-based, guideline-supported, and clinically useful in almost every patient population. The TSH and A1C are two other key labs that guide how we manage some of the most common chronic conditions we see. thyroid disease, and diabetes. For TSH, this isn't just about checking a box. Subtle changes can explain symptoms like fatigue, weight changes, cognitive decline, or mood shifts, especially in older adults. It is also essential before starting or adjusting thyroid medication. For A1C, it gives us a 3-month average of blood glucose control. In long-term care, A1C targets may be different than younger adults. We often focus more on avoiding hypoglycemia and maintaining functional status than achieving tight control. If you don't know what your goal A1C is, go to the American Diabetic Association. They have different A1C goals for certain age groups as well as comorbidities. So a patient with 85 years old with 10 comorbidities, their A1C goal may be 8%. Whereas if you're 55 and you only have diabetes, your A1C should be 6.5 or 6.0. So we're really trying to adjust the A1C based on what the patient and their age and comorbidities look like. These labs are also key for medication decisions, starting, adjusting, or deprescribing treatments. And importantly, they establish a baseline to track trends over time. Vitamin B12 and vitamin D3 are two labs that can make a difference in patients' outcomes, especially in older adults. Vitamin B12 deficiency can mimic or worsen cognitive decline, mood changes, weakness, and even neuropathy. In long-term care, where these symptoms are common, having a B12 level can help differentiate between something we can fix and something we can only manage. Vitamin D3 plays a huge role in bone health, fall prevention, and immune function. And importantly, vitamin D3 is preferred over vitamin D2 because it's longer acting and more effective in maintaining therapeutic levels over long periods of time. You'd be interested to know that vitamin B12 and vitamin D3 affect the mood, depression, and behaviors of a lot of older patients. And so these are very important labs to obtain. They're simple to obtain because they have big impact on quality of care and fall prevention strategies, especially in frail or high-risk populations. Put them in with your CBC and CMP, then you have your baseline. When we start or continue a statin, it's not just about putting a patient on a cholesterol medication and walking away. It's about understanding the why and the what to monitor. A lipid panel at baseline gives us a clear picture of where the patient is starting. It helps determine if the statin is indicated, if the therapy is working, or if it needs to be adjusted. The SED rate or a CRP can be very helpful adjunct labs, particularly in older adults or patients with multiple comorbidities. If someone develops myalgias, fatigue, or other vague symptoms after starting a statin, these inflammatory markers can help you differentiate between medication side effects and other inflammatory processes, or even an unrelated illness. The goal is not to over-order labs. It's to order strategically with a clear clinical purpose. That's what keeps your evidence-based practice survey proof. This is one of the most important lab discussions in this entire section. In long-term care, we see a lot of lower extremity edema, and the default is often CHF. But not every swollen ankle equals heart failure. A BNP or pro-BNP can help you differentiate between edema from venous stasis or medication side effects, simple volume overload from sodium or fluid retention, and true decompensated CHF that requires aggressive management. If BNP or proBNP is elevated, it supports a CHF diagnosis, but always interpret it in the context, such as renal function, age, and comorbidities. If it's not elevated, that's a strong signal to look for another cause rather than reflexively increasing diuretics. This lab does not replace a good physical exam assessment, but it supports better decision making, reduces inappropriate diuretic use, and helps clarify documentation and coding. Tegretol is one of those medications where lab monitoring is not optional. It's essential for patient safety. So carbamazepine can affect multiple organ systems. So bone marrow suppression leading to leukopenia, agranulocytosis, and even aplastic anemia. Hepatic metabolism, meaning regular liver function monitoring is required. And if you're monitoring the liver function, you might as well order a CMP, which gets the liver function as well as the kidney function. Electrolyte balance, especially sodium, as hyponatremia is a common complication. And of course, serum drug levels to ensure therapeutic dosing and avoid toxicity. This is why you'll also see a front-loading monitoring schedule. Frequent CBCs, LFTs, and levels early on, and then spacing out once stability is achieved. In long-term care and primary care, this is particularly important because patients may have comorbidities and polypharmacy that increases the risk of interactions and side effects. This is not a set it and forget it medication. If you prescribe Tegretol, you must commit to structured monitoring. If psych prescribes Tegretol, you must be committed to a structured monitoring. If the neurologist prescribes Tegretol, you must commit to structured monitoring. This is a medical monitoring, regardless of who prescribes the Tegretol. Lamotrigine doesn't require the same level of ongoing lab management as some of the other seizure medications, such as Depakote or Tegretol. However, that doesn't mean it's hands-off. There are times when monitoring is appropriate and clinically important. For example, baseline labs such as CBC and CMP are good practice, especially in medically complex or older patients. And it seems like we'd be doing that on every patient anyway. Monitoring may be warranted if the patient develops new symptoms like a rash, fever, or systemic complaints that could signify a hypersensitivity reaction. If Lamictal or lamotrigine is being used in combination with other epileptics, drug interactions can alter metabolism, and serum levels may be useful in some cases. Lamictal's biggest risk isn't lab-based. It's Stevens-Johnson syndrome with rapid titration or in sensitive patients. So while labs aren't frequent, clinical vigilance is essential. When ordering lamotrigine, you use the FDA packs. You can look those up and find out what pack you're going to use. You usually start with 25 for a week, then go to 50, and then go either to 75 or 100 milligrams. And I always write an order for the nurses to monitor for Stevens-Johnson syndrome. So the order says monitor for Stevens-Johnson syndrome. I give a couple of examples of what that is, including the skin rash where the skin starts sloughing off. And then I order it for every shift. So the nurses are monitoring that at least for the first 2 to 3 weeks. Keppra is one of the more straightforward seizure medications when it comes to lab monitoring. It's generally well tolerated. It doesn't require routine serum level monitoring in most cases and has fewer drug-to-drug interactions. However, that doesn't mean we completely ignore it. A baseline CMP is important since Keppra is primarily renally cleared, and dose adjustments may be necessary in patients with impaired kidney function. Periodic labs may be appropriate if patients have fluctuating renal status. Clinically, it's crucial to monitor neuropsychiatric side effects such as mood changes, agitation, or irritability, where common but are often missed. Serum levels can be ordered if there are concerns about non-adherence, toxicity, or therapeutic failure. While it's not...
I found some web results. I can show them if you ask again from your iPhone.
I apologize for that. So while it's not lab heavy, Keppra still requires thoughtful oversight, especially in older adults. Keppra is generally one of the easier seizure medications to manage when it comes to labs, but clinically, there are a few things that have to be on your radar. One of the biggest issues I see in practice is behavioral and neuropsychiatric changes, particularly in patients with pre-existing schizophrenia or other psychotic disorders. Keppra can worsen agitation, irritability, confusion, and even trigger delirium-like presentation. This can easily get misinterpreted as a primary psych exacerbation, urinary tract infection, or altered mental status. But sometimes it's actually the medication increase or start that drives these symptoms. So if you're starting Keppra or you're increasing the dose of Keppra in a patient with schizophrenia, dementia, or baseline cognitive impairment, it's crucial to know that their behavioral baseline and monitoring them closely for early changes is important. And again, while we don't need frequent serum levels for most patients, baseline and periodic renal function monitoring is key. Depakote is a medication that absolutely requires structured monitoring. Of course, we draw the standard labs, CBC, LFTs, because its effect on bone marrow and liver metabolism. But one lab that often gets missed is ammonia. Depakote can increase serum ammonia levels even in patients with normal liver function. Elevated ammonia can lead to valproate-induced hyperammonic encephalopathy, which may present as confusion, delirium, lethargy, or even psychosis in older adults. So when starting or adjusting Depakote, it's best to get a baseline CBC, LFTs, and ammonia level. Repeat the ammonia and Depakote level in 8 days and post initiation, and then every 3 months, unless you're doing another dose change. This is critical in the geriatric population, where the presentation of toxicity can be subtle and easy to misattribute to dementia or psychiatric illness. This is one of the most important and overlooked parts of what we do as nurse practitioners. Care coordination isn't just about making a referral and walking away. It means actively managing the handoff to make sure the patient actually receives the care they need. For example, when referring a patient to cardiology or neurology, it's not just enough to write refer to the specialist. We should clearly document the reason for referral, the urgency, any relevant labs or imaging, and what question we're asking the specialist to answer. Transition management means whether we're making sure that once a patient leaves our facility, whether that's to a hospital, to another facility, whether that's outpatient follow-up, there's a clear, structured communication about medications, diagnosis, and follow-up needs. This is also where solid documentation protects you. Why the referral or transfer was made, what your clinical thoughts were or process was, and that communication with the receiving provider occurred. We also have a YouTube training resource in the resource section that walks step by step through how to document a full referral note to keep things clean, clear, and defensible. This is the core of why it all matters. As nurse practitioners in long-term care and primary care settings, our work doesn't exist in a vacuum. Everything we have has to align with federal and state guidelines, survey readiness, risk reduction, and interdisciplinary teamwork. Our ultimate goal is to follow CMS guidelines and maintain compliance. Pass our ACA, CMS, Joint Commission, and RAC audits, not by scrambling at the last minute, but because our documentation and care already meet the standard. Defeat and prevent litigation by providing and documenting evidence-based defensible care. And then to collaborate effectively with the IDT, because care coordination and communication are at the heart of good outcomes. This is not about making your job harder. It's about practicing smarter, protecting your license, and improving care. In your notes, orders, and decision-making align with CMS and evidence-based practice, you will walk into any survey or chart review confident and able to meet the minimum criteria. This slide highlights why antibiotic stewardship is critical in long-term care. We know antibiotics save lives when used correctly, but when overused or misused, they create more harm than good, especially in frail elderly patients. We're talking about C. diff, resistance, drug interactions, and survey findings. As nurse practitioners, our job isn't just to order. It's to decide if antibiotics are needed at all, to make sure that we rely on McGear's criteria, to make sure symptoms actually meet infection thresholds, interact care pathways to guide when to treat, monitor, or transfer. Evidence-based protocol tools like EMRA, antibiotics, Sanford Guide, and Hippocrates to match the right drug, dose, and duration. We also need to document clearly the indication, the supporting clinical criteria, the planned course of therapy, monitoring parameters and reassessment. Antibiotic stewardship isn't about withholding care. It's about delivering the right care to the right patient at the right time and protecting our residents, our facilities, and our license. This slide is critical because if you only take away one prescribing safety tool, it should be McGear's criteria. McGear's criteria gives us standardized clinical triggers for diagnosing infections in long-term care residents. Why this matters. Long-term care residents often present atypically, no fever or clear symptoms. Overprescribing based on vague findings like cloudy urine or a little cough is one of the biggest sources of antibiotic misuse. McGear's provides objective, evidence-based thresholds for when an infection is actually likely. How to use it. You're going to use it before prescribing antibiotics. Does the patient meet the criteria for a suspected infection? Use it as part of your documentation. It gives you all the answers. You can clearly note which McGear's criteria are met. Use in combination with interact pathways to decide whether to treat in place or escalate. If criteria aren't met, monitor. Don't reflexively treat. This protects your patient, reduces resistance, and backs up your clinical decision legally and regulatory. If you're ever questioned during a chart review or audit, McGear's criteria can be your clinical shield. So if we pull up McGear's criteria for infections, you can see the top is constitutional criteria for infection. So it talks about if you have a fever, if you have increased white blood cells, acute mental status, acute functional decline. The second table talks about urinary tract infection. So if you're going to diagnose a urinary tract infection and this patient has no indwelling catheter, both part 1 and part 2 must be fulfilled. So part 1 gives a list of symptoms that the patient has. That's part 1. They have to meet that criteria. And part 2 says at least one of the following microbiologic criteria has to happen. So you have to have at least 50,000 of no more than 2 organisms. If you have 3, you have a contaminated sample. McGear's criteria is saying of no more than 2 organisms. Or if you straight cath a patient, then you should have 20,000 of any specific organism when you're doing a catheter. So the following 2 comments apply to both UTI with or without catheter. And it gives you comments in the McGear's criteria of what that means. So at the bottom, there's a UTI with an indwelling catheter. This says both 1 and 2 must be fulfilled. So part 1 is their symptoms. So do they have fever? Do they have rigors? This is stuff you document. Patient noted with fevers, rigors, no new onset hypotension, no alternate site infection. Those are the things that we're going to document. And then the second part, because you have to fulfill both to use that diagnosis of urinary tract infection, is you have to have at least 50,000 organisms from that straight cath or from the urinary catheter. So do you take it from the bag? No, you take it from the highest point. So you clamp it and then you pull it from the highest point. If you're ordering a urinalysis from a catheter, please make sure you write that on the order to clamp it for 5 or 10 minutes and then take from the highest area of the catheter and not from the bag. So McGear's criteria isn't just about urinary tract infections. They have cold symptoms, influenza, they have pneumonia, they have bronchitis. Did you meet those criteria? And it gives you the wording of your positives and your negatives. So what to evaluate and then what the patient doesn't have. So if the patient has cellulitis, they have to have at least one of these issues. So do they have pus at the wound, skin, or soft tissue site? And do you know how to do a wound culture? Look into that. Make sure you're doing it correctly. And then if not this, then they have to have at least four of the following new symptoms. So we're talking about heat, redness, swelling, tenderness, serous drainage, and then if you're going to use this, they could have fever, leukocytosis, change in mental status, and acute function, but 4 of these. So when you're documenting the 4, you can say patient noted with heat, redness, swelling at affected site, and a fever. Patient denies tenderness, there's no serous drainage, no leukocytosis, etc., etc. So when you use the McGear's criteria, it not only shapes how we diagnose, but it shapes how we document. This is where we go from, does this patient meet infection criteria, to what is the next best step for care? So once McGear's criteria confirms whether an infection is likely, Interact Care Pathways guides us through structured clinical decision making. Why this matters in long-term care. Well, residents often have complex comorbidities. Not every positive lab, let me repeat that, not every positive lab or subtle change means hospital transfer or antibiotics. Interact gives us evidence-based pathways to make decisions. So whether it's supporting in place or transferring to the hospital, it helps guide us in those pathways. It helps us standardize care across providers. So whether it's you or me, another nurse practitioner, the physician coming in, you never have to worry about them changing your meds, discontinuing and putting them on another med, because not only have you used the right medication per evidence-based protocols, but you've documented the correct way. It also helps us avoid unnecessary transfers, which is used to reduce patient risk and facility citations. The last thing we want is to have to transfer them to the hospital and start all over again. So assess the McGear's criteria first to confirm the clinical threshold, and then use relevant interact pathways. That we have them for UTIs, respiratory, mental status change. Follow the algorithm to guide you. Are you monitoring in place? Are you starting treatment? Are you escalating transfer to the hospital? And then document the clinical reasoning step by step. The key is McGear's criteria tells us if this is an infection. Interact tells us what to do next. So this is an example of an interact pathway. So the facilities should be using it. Are they? I don't know. Are the majority of them? Probably not. Are there rare facilities that use it? Hopefully. This is a great tool. Every facility should be using this. If they're not, I don't know what to say, but should we be using it? Absolutely. I love this. So this is the blue is what the nurses should be sharing with you. So if there are symptoms or signs of a UTI, they're going to tell you, and you're going to go in and do an assessment. Painful urination, lower abdominal pain, blood in urine, new or worsening. If that's the case, then they need vital signs. So your nurse should be obtaining vital signs such as your temperature, your blood pressure, your respirations. After they've obtained the vital signs, they should know whether they met any criteria. So is your heart rate over 100 or is it less than 50? Respiratory rate, blood pressure. So vital signs, are any of them met? If yes, they should be contacting you. Here it is, notify the MD, nurse practitioner, or PA. These are national standards. Your interact forms are national standards designated for skilled nursing homes. If there's no criteria for vital signs met, then the nurses should be looking for abdominal distension, worsening incontinence, suprapubic tenderness. But if you're in the building and you're there 4 to 6 hours, you could be in there doing this evaluation. These are things you document. Patient has no abdominal distension, is incontinent at baseline with no worsening, does have suprapubic tenderness, does have pain, I wouldn't, or it does not have pain, gross blood in urine. Now remember, if you have gross blood in urine, is it really a UTI or are they on Eliquis, Pradaxa, Xarelto, and do we need to hold that for 3 days? So remember to use your clinical judgment. Are they not eating or drinking? And do their signs and symptoms suggest sepsis? Know what sepsis looks like, know how to treat it. The last thing we want to do is send a patient over to the hospital in severe sepsis. We want to be able to identify it early. So if they have symptoms, come back over here and it says notify us. But we could be doing this exam. If no to all of this, consider contacting us. That's what they will do. And then we can order a urinalysis, which would be a urine PCR if you have those available. Those get done within 8 hours, and you should have the results at the end of the day. Urine culture and sensitivity, you could do blood work, get a CBC, find out what the white blood cell count is. If they have a catheter at the hospital, they've had it taken out, you could do a post-void residual. And then, oh, it read my mind, INR if antibiotic ordered, and on Coumadin. So if you do start them on an antibiotic, look at their INRs. So if you do an INR once a week and you put them on Levaquin, they should have their INR every 2 to 3 days, maybe 3. Were tests ordered, then evaluate. Again, this is in blue, so this is for the nurses, but would we be doing that because we're in the facility 4 to 6 hours? You betcha we will. Do we have a white blood cell count of greater than 14,000? Post-void residual of greater than 350? That catheter needs to go back in. We need to do bladder training again. If we can't take the catheter out, we may need to send them to the urologist. And then if the urine results suggest infection or presence of symptoms, again, if yes, here they come, and they're wanting guidance on that. If you're the one evaluating that, guidance on that. So if no to all of these, and we thought they had a urinary tract infection, but we followed the template all the way down, we can probably manage in the facility, monitoring the vital signs, the fluid intake, oral, IV, or I don't know what subcutaneous fluids is. Let's avoid that. Check results of urine and culture. Consider antibiotics if culture is positive. Discontinue antibiotics if culture is negative. Now, if we're waiting 3 days for the culture and sensitivity to come back and you have 4+ bacteria, it might be advantageous for you to start them on an antibiotic based on having a urinary tract infection. If you obtain a PCR, that result should be back that afternoon, and you will have the results of the organism and the susceptibility to the antibiotics. And then here, when we're notifying the nurse practitioner, we're going to monitor the results. So this is just an example of a care pathway. You've got multiple. You've got acute mental status change, behavioral changes, dehydration, fever, GI, shortness of breath, CHF, lower respiratory, UTI, and falls. If you are not using these for your positives and your negatives, you're missing out on great documentation. Before you prescribe, before you ever write that order or hit that e-prescribe button, you need to pause and think critically. Prescribing is not a reflex. It's a clinical decision that has a ripple effect on your patient, your facility, and your license. Here's what that pause should include. What is the actual problem? Are symptoms acute, chronic, or unclear? Are we treating a real condition or a lab value? Does the patient meet criteria, especially for infection, pain meds, or other controlled substances? What's their history and comorbidities? Could this medication worsen another condition, such as CHF, delirium, renal impairment? What's already on their med list? Think interactions, duplications, polypharmacy. Think about the lab results that we just barely talked about that potentially could cause delirium and increased mental status confusion. What monitoring will be required? Labs, side effects, follow-up intervals. What is the deprescribing plan, especially for antibiotics, opioids, psychotropics, people on short-term agents? This quick clinical gut check is how we protect patients and ourselves. Remember, your DEA, your license, and your facility can all be impacted by a single unsafe prescription. But more importantly, so can the patient's quality of life. This slide speaks to a reality that many of us see every day. We often don't order what we should, not because we don't know better, because of workflow, pressure, or old habits. Here are some common pitfalls that I want us to reflect on as prescriber. Assuming someone else has already ordered it. We have a lot of strong physicians in our facilities in Texas, as well as their mid-levels, whether they're physician's assistants or nurse practitioners. Don't assume that they are going to prescribe that or they will get mad for you for prescribing that. You are the in-house facility nurse practitioner. If there's any kickback from that, of course you can call me. Of course you can call whoever your vice president is. You can absolutely kick that back to us. But don't assume someone else has already ordered it. Ordering based on old patterns, not evidence. We always do it. We always do it this way. We've never done it this way. That's not clinical justification. If it's not supported by evidence-based practice, it may not be appropriate anymore. Avoiding orders to not rock the boat, especially in facilities with strong personalities or resistance to change. It's easy to default to minimal intervention. That's not safe medicine. But if you're following evidence-based practice, there can be no holes in what you've done. Lack of clear ownership. When the doctor, nurse practitioner, and IDT all think someone else is responsible, the patient falls through the cracks. Fear of over-ordering or getting dinged for cost. Remember, appropriate monitoring is not over-ordering. It's good clinical care and defensible in our audits. Our job is to stand confidently in evidence-based practice. If a baseline lab is needed, if monitoring is required, if consult is warranted, order it. Document why. That's what protects the patient and your license. If you have any questions, you have total and free access to me. Whether you text me, you call me, or you email me. You can email me if you have issues with providers, if you have issues with personalities, if you have issues with doctors discontinuing your orders. But that won't happen if we're using evidence-based practice. So if we do what evidence-based practice says we can do, it's going to be very hard to discontinue our orders or to say we're not doing the right thing at the right time for the right patient for the right length of duration. I want to thank you for your time. I know this was time out of your schedule. I appreciate you spending time with me this morning. I hope that you were able to get good information out of this. I hope you're able to take this and be able to utilize it in the future. As I send this URL out so that everyone has access to it, I will also be sending all of the McGear's criteria as well as the templates, the algorithms for Interact. If you ever need me for anything, I'm here for you. Please just reach out and let me know. And with that, I want to say thank you and have an amazing day.